Then coming over to SLE. So SLE is an idiopathic autoimmune multi-organ involvement. There are periods of relapse and remission in this. Among, like, if you compare the females and the males, females are more commonly affected. It is more common in Afro-Caribbean lineage than in Asians. Mostly they occur in early ages like childbearing age group. Causes we are not very sure, they are unknown. However, it can be triggered by some environmental factors like UV rays, viral infection, like Epstein-Barr virus, or there can be some genetic predisposition. So, because there is some genetic predisposition, so it has been seen that if there are monozygotic twins, 25% concordance, that is both the twins, chances of both the twins being affected is there. Okay. Then how do you counsel these patients? So about pre-pregnancy counseling, you tell them that fertility, however, is not reduced, but these patients are on various immunosuppressants and pain
Actually,
because
both twin will be affected in case of if mother is affected.
if mother is affected, yes.
Okay.
Then NSAIDs, because the NSAIDs, what they do, they inhibit ovulation, so it can have some effect on the fertility. Also, so NSAIDs, if the patient is on, they should be advised to stop it. And sometimes these patients are on cyclophosphamide, which are gonadotoxics. So these can result in ovarian failure. So they should ideally be avoided. Then anti-Ro, anti-La, and APLA antibodies. So these are positive. These may be present in SLE patients, and with anti-Ro, anti-La, it has been seen that congenital neonatal heart block. This is again a question with anti-Ro, anti-La positive in SLE patients. So in the baby, there is risk of congenital heart block, and also risk of neonatal cutaneous lupus. Then APLA antibodies, these are present in 30% of the patients. So we all know if APLA is there, then there can be risk of thrombosis, either arterial or venous. There can be risk of recurrent miscarriage, fetal growth restriction, fetal loss, and preterm delivery due to uteroplacental insufficiency. Okay. Then what are the conditions when you advise the patients against pregnancy? You ask them not to get pregnant. If there is pulmonary artery hypertension, yesterday also we studied this. Pulmonary artery hypertension, you do not advise them not to get pregnant because the maternal mortality rates are as high as 40%. And other things, even in active disease, if there is active disease, particularly with lupus nephritis, it is associated with worse maternal and fetal outcomes. So active disease also, you advise them against the pregnancy. So what are the effects on the baby and what are the effects on the mother? So for the baby, there can be risk of miscarriage, there can be growth restriction, there can be preterm delivery, there can be stillborn. So because there is growth restriction, you have to do a serial growth monitoring for these patients. And there can be baby lupus, that baby neonatal lupus can be there, so baby can be born with lupus. In a mother, there can be risk of pregnancy-induced hypertension. So any patient who is SLE positive, you have to give them aspirin. So according to the new guidelines, 150 mg from 16 weeks till term you have to give. Okay.
50 from 16 weeks.
Yes.
Okay.
16 weeks.
16 weeks.
Yeah.
Until then, 75.
No.
Start.
Early first trimester, so usually do not give. No, you start at only from 16 weeks.
But if there is a history of recurrent abortion, prophylactic dose we give, right?
If APLA positive, then you start. Otherwise, for SLE alone or other prophylactic doses, if you're giving for chronic hypertension and all, usually you start before, ideally before 16 week, you can start at 12, 13 any time. So usually you start around that time and you continue it till term. And there is risk of clots. So what is the score for SLE? Patient has SLE, what is a BPA score? Yesterday we studied. Yesterday, no, on Friday.
I forgot, ma'am. Is it 2?
No, it is 3.
3.
Any chronic disease, SLE, APLA, chronic hypertension, all that is 3.
Okay.
Then there is a risk of flare, there can be rash, and if the antenatal score is 3 and
Mm.
there are no other risk factors, then when do you start thromboprophylaxis?
If the score is 3, we have to start from 20.
20, 20 was not there. It's
We start in the first trimester when the score is for something. We start in first trimester
so how much is the score when you start in the first trimester?
for 3.
More than equal to 4, you start in the first trimester,
Okay,
continue it
it's
for
high
6 weeks.
score. Mm.
If it is more than equal to 3, then you start at 28 weeks and then you continue it for 6 weeks. Any patient whom you are giving this
Okay.
antenatal thromboprophylaxis during pregnancy, you have to continue it for 6 weeks postpartum.
Okay, 4 and above first trimester, 3 and above 28 weeks.
Yes. Okay. Now coming over to the diagnostic criteria. So these are 11 criteria, and if 4 of these 11 criteria is present, any 4, so then that makes the diagnosis of SLE. It has specificity of 95% and sensitivity of 75%. So
Okay.
what are these 11 criteria? Malar rash,
Mm.
discoid rash,
Mm.
photosensitivity, oral ulcer,
Mm.
arthritis, pleuritis or pericarditis, renal disorders, neurological issues like seizure, psychosis,
Mm.
hematological, which could be any hemolytic anemia with leukopenia or lymphopenia or thrombocytopenia, immunological, where these anti-DNA, anti-dsDNA, anti-Smith, SM nuclear, APLA, all these are positive. Okay,
Okay.
cardiolipin antibodies and or positive ANA, anti-nuclear antibodies are positive. So if any 4 of these 11 criteria is present, that makes
Okay.
the diagnosis of SLE.
Okay.
Then how do you investigate this patients? Because there is multi-organ involvement, so you have to focus on each system. For cardiac evaluation, in order to rule out pulmonary artery hypertension and other causes of heart disease, you have to do an echocardiography. For
Okay.
respiratory assessment, because there is risk of pulmonary fibrosis, you do chest X-ray. If required, CT scan. For renal, you have to do urine dipstick, protein creatinine ratio, because there is risk of PIH. You have to
Okay.
assess for the renal function because renal toxicity, particularly anti-DSDNA positivity is there. So
Okay.
lupus nephritis can occur. In order to rule out that, you have to do this renal function. And
Okay.
in case there is in on urine dipstick, anytime you find that hematuria is there or the patient has hypertension, renal impairment, you have to send the patient to the specialist. Hematological, you have to do a full blood count because there can be risk of because hemolytic anemia, neutropenia or thrombocytopenia can occur. And
Okay.
then you have to do APLA testing, anti-dsDNA, anti-ROLA testing, complement C3, C4 levels should be tested. So if C3, C4 levels are raised, there is risk of lupus nephritis. APLA, we
Mm.
all know that there is risk of pregnancy loss,
Mm.
and this dsDNA, risk of lupus nephritis again. ROLA is associated with congenital heart block.
Okay.
Then this was about the preconceptional counseling. Now coming over to antenatal care. So antenatal care, you have to involve the MDT, which will involve obstetrician, midwives, physician, hematologist. For those individuals who have stable disease,
Mm.
because SLE there is a risk of fetal growth restriction, so you have to do fetal growth scans every on 4 weekly basis,
Mm.
and if you find growth restriction, then you do Doppler also accordingly.
Okay.
Okay. And PP and proteinuria should be estimated. For those at particular risk of fetal growth restriction and or preeclampsia, you have to do more frequent assessment. Okay.
Okay.
Then risk of VT, so minimum score 3. If there are other risk factors, then the score will be 4 or more than equal to 4. So if there are no other risk factors, so at least you have to start thromboprophylaxis from 28 weeks, give it for 6 weeks. This you have to remember. Okay.
Okay.
And risk of SLE flare in pregnancy is increased with active disease in 3 to 6 months prior to conception. If the active disease has been there 3 to 6 months prior to conception, there are higher chances that SLE may flare in the pregnancy. And
Okay.
most of the flares they occur in the second half of the pregnancy. So this has been asked.
Okay.
Second half of the pregnancy, usually the flares are common.
Although they are on treatment,
Mhm.
even if they are continuing their medication for SLE.
Yes. Most of the times you will have to change the medications, because if they're on cyclophosphamide methotrexate, you'll have to stop it. You can give
Okay.
azathioprine, you can give HCQ, you can give corticosteroids. See,
Okay.
because of the changing of the medications, you cannot give all those strong immunosuppressants. So that's why
Okay.
flares are common. Also, this pregnancy is an immunocompromised state. So again, the flares are common, and they usually occur in the second half of the pregnancy. And in case they occur, you have to manage them expectantly
Okay.
with medical management and adjustment of the drug therapy. Because hypertension is common, you have to control the blood pressure.
Okay.
Then about fetal management. So there is increased risk of miscarriage, especially if associated with APLA.
Mm.
Then complete congenital heart block in the baby has been seen if mother is positive for anti-rola, because it crosses the placenta and destroys the Purkinje system. And
Okay.
usually the baby will present with fixed fetal bradycardia with
Mm.
heart rate of 60 to 80 beats per minute.
Okay.
And it occurs in 2 to 3% of the fetuses of women who are born to this anti-rola positive. And recurrence rate in subsequent pregnancy is 16%. So this is important. You have to remember anti-rola positive is associated with complete congenital heart block in the baby. Okay, and it usually develops between 18 to 20 weeks. So you have to do a fetal echo
Okay.
around that period to detect it. Okay,
Okay.
and also other risk factors in the baby include hydrops fetalis can occur in utero, and it is due to the it depends on the degree of endomyocardial fibrosis and associated myocarditis in the baby. So
Okay.
hydrops
How
fetalis.
the fetus is managed post delivery?
Fetus is managed post delivery. So again, you have to start in the similar manner at lower doses. You have to start steroids only to the baby also, in case there is flare. If there is heart block, then accordingly you manage. You give drugs for heart block.
Okay.
Then neonatal lupus, it present as these annular inflammatory lesions. These are common on face and scalp and appear typically after UV exposure in the first 2 weeks of life, but can
Okay.
occur even up to 3 to 6 months postpartum.
Okay.
The rash generally appears spontaneously and persists for up to 6 months postnatally until the neonate clears the maternal antibodies.
Okay.
It is rare for neonatal cutaneous lupus and neonatal heart block to occur together in the same individual. And if you do skin biopsy, if you do, you'll see immunofluorescence, which is typical of cutaneous lupus.
Okay.
Then, how do you manage these patients? So, during pregnancy, the first line management are glucocorticoids. Mostly, you give prednisolone.
Mm.
Usually these are safe for the baby, but certain, like, it can be associated because you're giving high dose, so they can be associated with malformations like cleft lip, cleft palate, and neonatal adrenal insufficiency can occur.
Okay.
Okay, so better is you give prednisolone, methylpred, or hydrocort, because these are
Mm.
more efficiently metabolized by the placental enzyme than dexamethasone or betamethasone, and
Okay.
therefore these cross placenta in small amounts only.
Okay.
Adverse effects in the mother include weight gain, immunosuppression, acne, GI irritation,
Mm.
and probably the most important adverse effects in pregnancy are impaired glucose tolerance. So you
Mm.
have to regularly for diabetes.
Okay. So it has to be started in the pre-conception period itself.
Yes.
Patients with SLE. They'll be
Most,
continuing. Okay.
most of the patients are on this. Either they are on this or they are on HCQ.
Okay. Otherwise, we have to change the drugs.
Yes. Other immunosuppressants that are safe during pregnancy are azathioprine or HCQ. So these are also safe.
Okay.
Drugs which can cause lupus-like syndrome. So even if SLE is not there, there are certain drugs which can induce the similar presentation, which include these sulfur drugs like hydralazine.
These drugs are also relatively safer.
No, these cause lupus-like syndrome, so they will aggravate the
Okay.
symptoms.
Okay. These should be avoided.
So
Okay.
these include hydralazine, procainamide, quinidine, isoniazid, diltiazem, and minocycline. So basically,
Okay.
glucocorticoids, HCQ, and azathioprine are safe.
Okay.
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 So these
So
are the various
start in the
drugs.
preconception period and continue throughout the pregnancy.
Yes. And
Okay.
if you're giving high dose of steroids
Mm.
uh, in the post, during delivery, whenever there is stress, you have to give stress dose of steroids. IV,
O-
you have to shift to IV hydrocortisone. So this
Okay.
applies for any patient who is on chronic steroid.
Okay.
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 So corticosteroids, these are anti-inflammatory, immunosuppressive. Dexamethasone and betamethasone, they cross the placenta. That's why for fetal lung maturity, you give this.
Yeah.
You want it to cross the placenta and cause lung maturity.
Okay.
However, for SLE, you don't want because you're giving very high dose.
Okay. Okay.
So then you give prednisolone and hydrocort.
Okay.
And long-term follow-up is required because these are associated with certain congenital malformations, especially if high dose is given, like cleft lip, cleft palate is seen. And some however, there is no significant neurodevelopmental delay.
This cleft lip, cleft palate seen for prednisolone and hydrocortisone.
If they're on chronic steroids, so it has been associated with it.
But they will be throughout their pregnancy. They'll be taking throughout the pregnancy. So there are chances for the fetus to be affected.
Yes, there are chances.
Okay.
Although very small amount crosses, but there are chances. But cleft lip and cleft palate are manageable, no? So they're
Yeah.
not
Yeah.
life
Yeah,
threatening
it's not going
things.
to
So
harm
you
the
can
baby.
so breastfeeding, if the patient is on steroids, is safe and you continue it during the pregnancy.
Okay.
NSAIDs, these inhibit COX enzyme. The problem with it is they cause premature closure of ductus arteriosus. So
Okay.
usually they're not given in the third trimester. You never give NSAIDs during the third trimester
Okay.
because of this problem. So you avoid after 32 weeks. Safe post delivery you can obviously give. Okay, so
Okay.
you just ideally do not give NSAIDs during pregnancy or even in the preconception period because they inhibit ovulation also.
Okay.
Okay,
Okay.
azathioprine, I told it is again immunosuppressive and it is safe. There are no
Okay.
congenital malformations that have been
What
reported.
if any single dose taken by mistake?
A
NSD.
single dose usually does not cause much harm. Usually we do not advise NSAIDs.
No, no, like if patient takes by mistake.
Do not do anything.
Okay.
But there is a risk of premature closure of ductus
Yeah.
arteriosus. Then, azathioprine, you continue. It is safe during pregnancy and breastfeeding, so you continue during the pregnancy. Methotrexate is not safe at all.
Okay.
Stop it at least 3 months prior to the pregnancy, and it has been associated with risk of neural tube defects. And if the patient was on methotrexate, you have to give 5 milligram folic acid.
Okay.
Mycophenolate mofetil again has to be stopped at least 3 months prior to the pregnancy. It is associated with miscarriage and congenital malformation, so avoid it during pregnancy and breastfeeding.
Okay.
Cyclophosphamide again is teratogenic. Also, it causes POF, premature ovarian failure. It causes risk of congenital malformations and miscarriage, and it is also excreted in the breast milk. So it's
Okay.
not safe during pregnancy and breastfeeding.
Okay.
Cyclosporin, it is associated with prematurity and low birth weight. During breastfeeding, it can probably be given. HCQ is again safe during pregnancy and breastfeeding.
Okay.
Okay. So, what are the medications for SLE which are safe during pregnancy and breastfeeding?
Prednisolone, hydrocortisone,
Okay.
hydroxychloroquine,
Hmm.
azathioprine.
Hmm. Yes. Now coming over to postpartum care. So postpartum also there is risk of lupus flare.
Okay.
Ongoing management and treatment. If the patient has PIH, you have to manage it. Assess the risk for thromboprophylaxis. This I've already told. At least the score is 3, so you have to give it for 6 weeks postpartum.
Okay. So we
And
have to start from when score
sorry.
of three. Score of three. So starting from 28 weeks.
If there are no other risk factor, if you feel that along with SLE there is hypertension also, or the mother's age is more, so then the
Okay.
risk factors is more, then you have to calculate the score. For SLE alone, the score is 3.
Okay. 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 Okay.
Okay. So then you have to add accordingly. So minimum you
Okay.
have to start from 28 weeks. You have to give it
Okay.
thromboprophylaxis to all patients.
Okay.
Okay. And because there is high risk of venous thromboembolism, so what contraceptive will you not give?
We don't give combined oral contraceptives.
You do not give COCs or estrogen containing pills. Because one, they increase the risk of VTE, also they increase the chances of flare in SLE.
Okay. Chances of
Flare,
how?
they aggravate. It has been seen that they aggravate the symptoms of SLE.
Okay. And how about aspirin? What you said?
Aspirin start from 16, before 16 weeks. Ideally, it should be started. So whenever
Okay.
it's diagnosed, you ideally start first trimester. Usually uh, we can give, but sometimes we are afraid in IVF pregnancy, so we give it to all. But for other pregnancy where there are risk factors, usually risk factors for hypertension also, when you how do you diagnose at 12 weeks if there is some diastolic notch, right?
Okay. Okay.
So you ideally start from like first trimester and you continue till 37 weeks. The best
Okay.
benefit is seen when you started before 16 weeks.
Okay. And in SLE case, we are giving any of these drugs. Okay. They may be taking a combination of these medicines along with aspirin also.
Aspirin you have to give.
And how about this LMWH, enoxaparin?
LMW also minimum for 28 weeks. Start from 28 weeks. If other risk factors are there, then you have to give it throughout the pregnancy. If
Yeah.
APLA
First,
positive,
if
again
there
you
is
have to
history of recurrent abortion, we have to
yes,
start right from their
yes, yes,
conception.
APLA positive again. Start right when we
Okay.
get.
Like how many doses? How it's given?
So for
Like
APLA positive, you give therapeutic dose. So I told you
okay,
therapeutic is 1 mg per kg PD.
okay, like
Prophylactic is 1
every
mg. So if APLA is not there, then you give prophylactic dose. So prophylaxis is 1 mg OD. So usually average weight we take as 60 kg. So we give
okay,
60. That Clexane comes as zero point 0.6 and zero point 0.4. So
okay,
if the patient is very lean, you give zero point 0.4. Otherwise,
okay,
the majority of the patient are around 60 kg. So you give that 6.6.
okay. So daily
Yes.
until when it is stopped?
Uh, this prophylactic dose I told you, if you're planning
Yeah,
for
for
delivery, 12 hours. Therapeutic 24 hours.
okay, okay. Aspirin up to 36 or 37 weeks.
To 37 weeks, yes.
Okay.
Okay. Any other doubts?
No, ma'am.
This was all about SLE.